Welcome to the Olympic Medical Center CMS training course for regulatory compliance, September 2025. My name is Sandy Garcia. I'm a registered nurse. I've been a registered nurse for over 37 years. My background is surgical services and emergency services. I have been consulting for the last 15 years, and I did survey with the Joint Commission, surveying to the standards, elements of performance, and the CMS conditions of participation. I work for a company named Chartis, who is a leading national healthcare consulting firm. Our team focuses on regulatory compliance and sustainability. During the session, please feel free to scan this QR code and submit your questions. We will then be following up on those questions and sending out an FAQ with the appropriate answers. Why are we here today? Well, we have actually had 5 CMS surveys since February of 2025. The first one was in February. I'm sorry, it's actually 4. We're anticipating the 5th. February of 2025, April of 2025, where the organization received an immediate jeopardy. That was abated before they left. They returned in June of 2025, and our last survey was in August of this year. Our plan of correction was submitted on the 5th of September, and we are now here getting trained on what we said that we would do to rectify the condition level finding, which was a nursing service. We anticipate a resurvey prior to the termination date of 10/10/25. What does the termination date mean? That means that we will lose our Medicare and Medicaid funding and reimbursement on the 10th if we do not correct this condition, which again lied in nursing services. The topics we're going to discuss today are pediatric behavioral health and substance use disorder response, neonate glucose management algorithms, documentation of monitoring assessments and reassessments, titration of medications, patient disposition, massive transfusion protocol, restraint and seclusion, and then we'll go over next steps, what's going to happen in the next few weeks. A reminder for the emergency department, this was a Washington Department of Health citation, not part of the CMS survey. However, we do need to comply with these requirements, these state requirements. So again, remember, for pediatric immunization, we must document that in EPIC. We did get to look at several records from 2 days ago, and they actually, both ER pediatric patients, the documentation was compliant. So good job, ED, keep it up. Just a reminder that your handoff process, whether it be to each other as nurses, as CNAs, as techs, or nurse to physician handoffs, you use the SBAR here, which is Situation Background Assessment Recommendation. Remember that the recommendations that you give to the physicians are intended to be suggestions to consider. We know that you are trying to provide the care. We understand that the providers write the orders, but we do expect staff, nurses, to actually call and clarify things that need to be clarified with the physicians. Just a reminder, the providers are also receiving this education and understand that we are asking you to ensure that orders are clarified when they're not complete or when they're confusing. Let's start with pediatric behavioral health and substance use disorder. The issue here, when the surveyors came in August, was that we didn't have a pediatric behavioral health and substance use disorder policy. We had an adult behavioral health crisis policy, but that did not address the pediatric or adolescent population. So there's now a new policy, which you should find on your SharePoint site or your hub starting on Monday, which will be September 15th. If you are listening to this after the 15th, you should be able to find that on the hub today. Remember, the these requirements for adolescents and pediatrics specific to behavioral health are driven by state regulations. There's resource guides available at the nursing stations of the ED, ICU, and Med-Surg. Again, they will be available on the 15th, and when you're listening to this, they should be available. We want you to know where those are so that you could use those as resources versus having to go to the complete policy. These resource guides were developed by you, an OMC multidisciplinary group that consisted of physicians, nursing, social services, and management. Here's a snippet of the policy, but again, we encourage you to read it. Here is an example of a resource, and again, this does address the pediatric patient population. Here is the behavioral health workflow, adults, adolescents, and peds. One question that came up over the last couple of days was, will this replace the workflows on Med-Surg and ICU that are separate from the ER, or will those resources still be in effect? Please check the FAQs for that answer in the future, but at this point, we're going to consider this an additional resource until notified otherwise. Here's an elopement reference guide for your use as well. Patient requesting, demanding to leave the hospital prior to release or discharge, what to do. We also understand that you are utilizing burgundy-colored scrubs for those patients to identify those. It's also come to our attention over the last couple of days that the burgundy scrubs were limited, so an order's been placed by senior leadership, and those scrubs should be here no later than tomorrow, September 12th. We are meeting with senior leadership on a daily basis, so if you find things out, supplies that you don't have to be compliant for this survey, for example, these scrubs, please escalate that to us, to Liz in regulatory, or anybody in the quality departments. Let's talk about neonate algorithms, baby glucose management. During the survey, the hospital was cited because the algorithm and policy were not current. However, there was really a misunderstanding with the survey team because policies are to be updated every 3 years. Unfortunately, the algorithm today is still dated 2020. That's due to Providence St. Joe's health algorithm not being updated, and we use their Epic version under their healthcare system. We're not able to change that. However, this algorithm has been approved and adopted. There is much more to do on this policy and on this algorithm to match current practice and regulatory requirements. We do know there is some things on here that you may or may not do. If you get an overriding order, that will take precedence. And again, this will be on the list to work on after we get the condition level removed on our next survey. Monitoring and assessment. If it's not documented, it wasn't done. CMS citations were broad here. This is a list: neurochecks, INOs, routine vital signs, post-op vital signs, newborn vital signs, maternal vital signs, PACU assessments, neonate assessments, maternal uterine reassessments and checks, and then mag sulfate specialized assessments. Again, if the order is unclear, please call or get a hold of the provider to get a clarification order. Please ask that provider to enter the clarifying order. We're seeing a lot of orders throughout the facility that may say vital signs / neurochecks, no direction, and also expecting neurochecks to be done every time vital signs are taken. So again, if you feel that that's not the standard on your unit, please call the provider, find out why that order was written that way, and see if that order can be changed. Again, the provider then should enter that order, unless it's an emergency or impractical, and then you can take a telephone order. There are tip sheets available. We will begin care facilitation on Monday, November 15th, and I'll explain a little bit more about that in just a few minutes. Let's talk about titration, the case of the RAS misconnection. The hospital was cited because the staff did not follow the provider's orders for titration, and we didn't document the RAS scores according to policy. When we looked at your policy, it did not address titratable drip management in general. It was a policy addressing the RAS score. The RAS score also was required outside dosing adjustments, which we have thus removed from the policy that, again, will be posted on Monday, September 15th on your shared policy library/hub. Worthy notes on documentation. As far as the policy, there's no required frequency in which targets should be documented outside of dosing adjustments. So you need to document while you're dosing, but you're not expected any longer to document additional RAS scores. Weaning drips, something to take note of. I think as far as a nurse is concerned, especially in the ED and the ICU where you're titrating frequently, you'll find this much easier for you to actually titrate meds and take care of the patient. The policy now says when the infusion has been weaned to off with the patient stable and at goal for at least 6 hours, you as an RN may discontinue the order. In the event that the patient's response is less than adequate after the increases, an increase in dose adjustments or decrease in frequency is warranted to treat critical life-threatening hypertension. The physician will be notified as soon as possible. It doesn't say prior to institution of the order, but it does say as soon as possible. That gives you some leniency to actually get a hold of that provider. And when titrating a drip down, the dosage adjustments may be less than the ordered amount in order to minimize the risk of rebound hypertension. At that point, no physician order is required to titrate drips down slower than the orders. Also, in policy, we did not address those transfer patients that are having titrations. Now, the policy says the receiving nurse will continue infusion rate at set upon arrival of patient until orders are entered, EMS arrival, or transfer into ICU. That way, as nurses, you continue titrations and you're covered by the existing order that is present. Here's a copy of that management of titratable drips. Again, you'll find this on the hub starting September 15th. A reminder, changes in titration, document the score to support your action. Again, this is while you are dosing. Let's talk about patient disposition, transfer order, and EMTALA form. This was not an EMTALA violation. Again, this was not an EMTALA violation. This was missing autographs and also disposition. So the hospital was cited for the following: lack of authentication by the patient. They did a verbal, but there was no documentation in that record indicating why the patient couldn't sign that transfer form. So again, it's acceptable to get a verbal order, a verbal authentication by the patient, but you got to document why. If that can't be done on the transfer form, then anywhere in the nurse's notes will be acceptable. The hospital was also cited for lack of authentication by the provider and lack of signed disposition. Now again, the survey team actually wrote lack of signed disposition order by the provider because we did not have anything in place indicating that the disposition was acceptable as written by the provider. The charge nurse will perform concurrent audits for these patients transferred to ensure we get complete documentation. So anybody that transfers, please ensure your charge nurse is notified so that he or she can actually perform an audit in real time. Documenting disposition in the ED or anywhere else, there's a tip sheet. And again, confirm that the transfer disposition is in and documented by the provider. Again, we need to ensure that disposition section is completed by the provider and nurses complete their section. In the past, I understand that the emergency department has assisted the providers in that documentation, but we want to move to ensuring that the provider does this. And again, they are being trained to this as well during this time frame. Let's talk about massive transfusion protocol, MTP. Great documentation is proof of great care. If you don't tell the story, you're not taking credit for the care that you're giving. Citation reasons for MTP was lack of provider order to transfuse, temperature monitoring, and no provider orders to discontinue blood following initiation of MTP. The reason that there was no order to transfuse is the provider did not use the order set for MTP. Again, please encourage the providers to use that order set so nurses are covered to transfuse. So as nurses, we went ahead and transfused, but we didn't have an order covering that transfusion. Temperature monitoring with the vital signs is required during transfusion, so please make sure that that's documented. And then we'll discuss the discontinuation. So what did we do to intervene on this? The policy was reviewed on August 27th. Nurses, like other things, will mark orders complete to end the MTP. That way, that order does not linger throughout the patient's stay. Nurses will obtain a complete set of vital signs, which will include temperature, as soon as possible upon initiation of MTP. So again, if you initiate MTP and those vital signs and temperature are put in a little later, that's acceptable now in policy. And again, repeat every 15 minutes for duration. The ED charge nurse is going to concurrently audit MTP documentation. We do know that MTP is ordered in other locations outside the ED, but for this exercise, the ED was the one cited, so that's where we're going to intervene and monitor. In the future, though, we will take note that we need to concurrently audit MTP throughout the organization. The house supervisor needs to be notified, and they will facilitate MTP debriefs using a critical documentation checklist. And you all, I'm sure you've already received multiple emails. We'll discuss these interventions during huddles and other discussions. Here is the MTP protocol with the activation guidelines. And again, you'll note that this is current as of August 28th, 2025. Again, a reminder, when MTP is stopped, mark the order complete like you do other orders. Restraint and seclusion. What do we do here? We looked at your policy, we simplified it, we updated it, and then we made some process and document changes. Let's go over the two types of restraints. We have nonviolent, non-self-destructive restraints. We have violent and self-destructive restraints. Nonviolent examples are if those individuals are in an area where they're intubated, pulling at tubes, pulling at IVs that may threaten life and interfere with necessary care. Violent restraints include physical escorts, holds, and physical holding for forced medications. Restraints are also, seclusion is also considered a violent self-destructive restraint. Just a reminder, forensic restraints are those used by law enforcement and are not affected by these regulations. Seclusion is involuntary confining a patient alone to a room or an area where the patient is physically prevented from leaving. Seclusion, again, is always a violent self-destructive restraint. So that means additional monitoring, Q15 minutes by an observer, trained observer, and then documentation by a nurse every 2 hours. Seclusion is not confinement on a locked unit or ward where the patient is with others. Having the patient agree to confine their movements to a room. And again, the key here is agreement to confine their movements to a room or a timeout in a quiet location that is unlocked. Chemical restraints. We don't do this. CMS does not like when hospitals use chemical restraints. And most of the time, I think you'll find that you are not using chemical restraints. I am not a chemical restraint when you're using Ativan for the management of the violent behavior. If Giordana is used for management of violent behavior, if the patient's suffering from a diagnosis of schizophrenia or bipolar disorder, Haldol for extreme anxiety, and inability to calm patient to perform necessary assessments, and the FDA-approved use of antipsychotic medications to manage violent behavior. The key here is, did we use a standard treatment and a standard dose to enable the patient to participate in their plan of care? If yes, that is not a chemical restraint. If we disabled the patient, if we worked outside the standard treatment and the standard dose, then that could be considered a chemical restraint. Again, please, if you see physicians writing outside the standard treatment and standard dose, please get that order clarified and ensure they understand that we do not use chemical restraints in this organization. What were the citation reasons? The hospital was cited for the following reasons: failure to follow policy for restraints, provider orders before initiating restraints or seclusion, and we're going to make this much easier in your new policy. We didn't discontinue restraints at the earliest possible time, and we didn't assess and monitor for violent restraints as required by the regulation and policy, and the medical staff training did not happen where they actually attest to reading the policy upon hire and prior to writing a restraint order. So let's talk about what the old policy said and what the new policy says. Again, which will be available on September 15th on your shared drive, your policy resource library, or your hub. If you are having difficulty finding these policies, please escalate that to your charge nurse and or director of your department. The old policy is in the blue or the dark letters here on the slide. The new parts of the policy are in red. So let's go over the old first. The restraint or seclusion must be discontinued at the earliest possible time. That will stay regardless of the length of time identified in the order. It was the old, it's the new. The new includes, for patients in restraint or seclusion, observed behaviors are documented at regular intervals as described in the documentation section below. The episode should only continue if the documentation of the observed behavior demonstrates a threat to the immediate safety of the patient, staff, or others. If the documentation does not demonstrate a threat, the episode must be discontinued. So this gives you more clarification, more explanation to the providers that we have to discontinue this episode of restraints when that threat does not exist. Nonviolent restraints. Physician or a licensed independent practitioner may order those. They're placed prior to initiation of the restraint whenever possible. Again, we added this language in the new policy to say if you need to place those nonviolent restraints, go ahead and do so, and then that order can be placed soon after. So again, for example, if I am going to place the patient in restraints at 7 a.m. in the morning, and the provider comes and documents those restraints, that restraint order at 7:05 a.m., you will no longer get cited because our policy supports this. Seclusion, again, is ordered by a physician or licensed independent practitioner. We added must place order after initiation of seclusion and within a few minutes of initiation. Again, that gives us time to call the provider and get the order placed. And if the time frames are a few minutes off, we allow that in policy and we will not be cited. The face-to-face evaluation is done using the OMC SMART phrase to complete all regulatory required elements. Remember, the face-to-face must be done within 1 hour after initiation of violent self-destructive restraint, which includes seclusion. That must be done right now only by a provider. Only by a provider. Otherwise, a nurse has to be specially trained, and we do need to investigate the stance of the State Board of Nursing in the state of Washington. So again, we want the provider at this point to do those face-to-face evaluations. Seclusion is documented every 15 minutes by a trained personnel or nursing. If it's that trained personnel, a CNA, we're asking you to document the observed behavior. We're removing the requirements for a trained personnel or CNA to document physical comfort, signs of injury, continuous observation, and visual monitoring. Again, focusing only on the observed behavior. When that behavior changes, please notify the nurse. This old documentation really was assessments that should be done by nursing, and nursing does complete those assessments every 2 hours. So again, as trained personnel, CNAs, we're asking you just to document the observed behavior and notify any changes in behavior to your nurse that's in charge of that patient, or escalate to the charge nurse. There's been some addition to staff education for seclusion and restraints, but again, this is not something that you got cited on. However, we wanted to ensure that you knew that we added competency to your education. The CMS regulation for staff education includes that staff will be oriented upon orientation prior to initiation of the restraint at your organization, the first time you actually put on restraints, and then on a periodic basis thereafter, where you define periodic as annual. So let me tell you what you actually do here at OMC. You actually conduct a competency upon orientation where you're trained to actually put on restraints, and then you do a health stream module. That does suffice the requirement of having 1 competency and 1 educational session before you actually apply restraints. And then again, you do that annually to be in compliance with the requirement of periodic training thereafter. Again, you were compliant with staff. The citation that was written was specific to the physician or the licensed independent practitioner that ordered the restraints. Again, the requirement for those practitioners is to actually attest that they have read and understand the restraint and seclusion policy within 90 days of privileges granted date, but before they actually write those orders, and annually thereafter. So again, the providers and the physicians are being educated to ensure that they understand that before they write that order, they must ensure that they've attested that they understand the policy for doing so. The house supervisor will respond to concurrent violent restraint and seclusion episodes. So again, if you have a violent restraint and seclusion episode in your department, please let the charge nurse know and ensure the house supervisor is informed, and they will come down and concurrently audit side by side with you to ensure that we capture all the documentation that is required. As of Monday, September 15th, we have let CMS know that we are in compliance, and again, they will come back within the next couple of weeks to ensure that what we did and what we said and what we do is compliant to their CMS Centers for Medicare and Medicaid conditions of participation are compliant. Let's talk about next steps. We want to make sure we're doing what we said we were doing. We want to prove that to the survey team in the next couple weeks, and we will. So what happens next? Yesterday, on September 10th, we actually trained care facilitators. These are staff that actually work in your organization. They range from informatics staff, CNAs, nurses, charge nurses, and they wanted to participate in care facilitation. They wanted to learn about it. They wanted to be able to audit and help be compliant so that we're successful on the survey. So we educated them on what the care facilitation process is. It's concurrent monitoring that reinforces compliance. We're monitoring clinical activities and correcting deficiencies in real time. We can't make changes if we're looking at closed records. We can make changes if we're working and auditing side by side while you're actually doing your clinical work. It's reinforcing practice changes and educating staff in real time, and it's providing data for analysis and oversight of corrective actions. Again, why is it so important to do concurrent monitoring versus retrospective monitoring? Concurrent monitoring allows for role modeling of care based on policy, quality standards, and practice expectations. So these are the experts that will have the knowledge of policy and what's expected, and they will give you many teachable moments if you're unsure. It allows staff to replicate improved practice. It's repeatable, sustained care processes as issues are identified, corrected, and improved. Again, when we leave, you can actually use this process to continue concurrent auditing. Again, we are educating your people to participate in care facilitation. We will be by their side for the next 3 weeks, ensuring if they have any questions, they have a resource to go to as well. Again, feel free to reach out to the care facilitation team, which you can reach them through the quality and regulatory team. And again, we will be around at least for the next 3 weeks through the month of September. Feel free to reach out to us, the Chartis team, as well. So let's make this happen. I want to thank you for your dedication to excellent and safe patient care at Olympic Medical Center. I know we can do this, and we'll do it together. I want to reiterate what I said in the beginning of this PowerPoint presentation. Please scan that QR code that's in your PowerPoint packet. Please ask any questions that you have through that platform, because I guarantee you, if you have a question, so will your colleague, and we want to ensure that you get answers to those questions and everybody can read through those on an FAQ or frequently asked question platform. So again, let's make this happen. Let's have a great time, and we will see you around. The Chartis team will be by your side again, at least through the month of September and through the survey process. Thank you and have a wonderful day.